Hi, this is my presentation on Microbacterium tuberculosis. Alright, just to give you a little history, it was first discovered in 3400 BC. They first found mummies that dated back to that time with the disease found in their spines. Back in the 1700s, it was also known as the White Plague. And then in 1882, Robert Koch had first discovered the rod-shaped bacteria that we now know as tuberculosis. At that time, he had just finished his other studies, and that's what brought him to discover the bacterium. In 1905, he was then awarded the Nobel Prize for his discoveries. And then since then, it has become known as Microbacterium africanum and Microbacterium bovis. Some of the signs and symptoms that they are into two different categories, latent and active. During the latent stages, they don't really have any signs or symptoms. The granulosums are able to do their thing and protect the body. During the active phases, people do experience fevers, chills, anorexia, not wanting to eat, unintentional weight loss, night sweats. They have a persistent cough for 3 or more weeks. They also experience coughing up blood. And then you're able to first diagnose it about 4 to 10 weeks after exposure. This just kind of gives you a different test that it goes over, in which when you will come up positive versus negative. As you see, it's got the TST cultures, and then which it will go into the latent or the active phases, into when you will show up positive. The steps into how it affects the body, first of all, it is an airborne bacterium. So it is spread from contact through droplets in the air, coughing, sneezing, any of those. So it first enters to the lungs, and then it goes into the alveolar space, and then from there it goes to the lungs interstitial tissue. After that, then the dendritic cells, or the inflammatory monocytes, transport the bacterium to the pulmonary lymph nodes. From there, the body does try to fight it off with its T cells and B cells by producing the granulodum. If the bacterium does become too much and overpowers the body, it does start spreading to other organs, including the brain and spinal cord. After that, it does travel to the bloodstream, back to the respiratory, and that is how you become contagious. And that is also how it is spread through airborne. There are different tests that they have to diagnose you with tuberculosis. The first one is commonly known as the PPD. It is a 2-step process. You will get your first one. It's just a needle prick right underneath the skin. It is considered what you call a bleb. And you would go back to the doctor about 48 to 72 hours after it is to be read. The next one is the blood test, or the interferon gamma ray release arrays. It is to detect the antibodies. This one is preferred for anybody that has had the vaccine, because it is able to differentiate the difference between an active and a latent. Because it is a live virus that it is being injected into you, the blood test is able to differentiate it from just the normal PPD. The specificity of the PPD is 70% and the sensitivity is 98%. Unfortunately, this test alone is not able to tell the difference between active and latent diseases, or which phase you're in, whereas the blood test can. After it is confirmed that you do have a positive test through the skin test or the blood test, you will more likely be sent to get a chest x-ray, and what they look for in that is for the spots on the lungs. That is how they're able to tell you if you are active or latent. That is kind of their secondary to make sure. Or you have the sputum culture, which just specifically tests for the bacteria. It does, how that one is taken is when it's from the phlegm that you cough up first thing in the morning. That is most of the time where it is the most potent, is in you have the most bacteria. Here is the Bcg vaccine that I was mentioning. Like I said, it is a live virus and it is given IM. However, the mechanism of action is unknown because it is also given for bladder cancer. So for that one, it does have anti-tumor effects. It is recommended for children under 5 due to the high rate of infection in the foreign countries, and it is also given to recommended for healthcare workers that deal with this bacterium quite frequently. At this time, the contraindications are immunosuppression and pregnancy. The side effects are some of the normals with IM injections: swelling, pain, tenderness, fever, fatigue, sore arm. Of course, there are some of the other ones the more serious ones, bone pain, but those don't happen nearly as often. The epidemiology, it is a worldwide disease. It is primarily in South Africa, where it is a lower income country. Men are more like 2 times likely to get it than women. Infants, like I had mentioned, children 5 and under, they do have a higher risk of developing it. And then again, once you hit about pre-teenage years, and then it seems to simmer down after you turn 25 and older. The major risk factor are HIV patients, just because they are already immunocompromised. They, on average, make up about 0.5% of the population. And out of that 0.5% of the population, 12% of those cases yearly are HIV patients. HIV or TB related deaths every year from HIV patients are about 25%. And out of that 25% worldwide deaths yearly, 75% of those do come straight from Africa. Other risk factors that are known are diabetes mellitus type 2 or excessive alcohol consumption. So just to go over some of the drugs that they do use for this, the first one will be the first line. These are all oral, and the treatment for them are quite lengthy. Rifampin, ionizide are the 2 main primary ones that we do use. There are others that for rifampin and ionizide become an MDRO. Then you go to the IMs, you have the streptomycin, viamycin, and then it does progress from there. All right, thank you.